Okay, this is chapter 95, substance use disorders. We are not supposed to call it addiction anymore. It's not politically correct. It is now SUD, substance use disorders. And when we talk about substance use disorders, there are lots of risk factors, sometimes difficulty responding appropriately to stress or stressful situations, low self-esteem. You kind of go along with the crowd. What are you, chicken? Take this, and people will do it. Trauma, past trauma, family histories, avoidance of these kinds of problems sometimes will lead people to make the problem go away, or I don't want to think about it, kind of self-medicating. All of these things are risk factors. There's also a genetic component, and there are multiple scholarly evidence research-based articles out there that have proven there definitely is a familial or heredity type component to this. So if you see families where there are multiple people that have substance use disorder problems, it's not a coincidence. It does run in families, whether it's alcohol, drugs, or both. And you really have to be patient with these patients, no pun intended, because they can be, a lot of work. So the DSM-5, we all know what that is. That is what we use to make these diagnoses. And again, abuse was replaced with substance use disorder. And the DSM-5 will go through the different types of substances, alcohol, opioids, benzos, almost anything. You really can be addicted to anything. You can be addicted to sex, to gambling, to shopping, to eating. Right. So when we talk about addiction, or a disorder with regard to a particular substance, to be politically correct, it can be a number of things that someone can be addicted to. And addiction, by the way, can be psychological or physiological or both. And that's important to remember. What happens when people have substance use disorder? Recurrent use of alcohol and drugs can cause things like delirium, dementia, psychosis, sleep disorders, cirrhosis of the liver. The big one with alcohol is hepatic encephalopathy, and we'll talk more about that in a minute. Eating disorders, nutritional deficiencies, organic brain damage. In other words, you do it so much that the damage to the brain is permanent and you can't go back. People that have these kinds of problems, they usually can't, meet their major responsibilities. They usually will get fired from their job sometimes, although for years there was something called a functioning drug addict or a functioning alcoholic, if anybody's ever heard that term before. And that means that they may have a substance use disorder, but they get up, they go to work, they pay their bills, they seem okay, but they still have an underlying problem. People that have addiction issues can have impaired control. Sometimes they'll get arrested frequently, drunk driving or driving under the influence. And it'll keep happening, and they'll keep on using the substance, even though they can go back and forth to jail and all the other negative consequences that are associated with it. It's been considered a long-term chronic illness. That's not anything new. And what happens with any drug that you're taking, the longer you take it, the more you need. Your body will develop a tolerance to pretty much anything. So even something as benign as like Tylenol, right, or Advil, if you take it on the regular for a very long time, you're going to need more to address your symptoms. Particularly with opioids, people wind up starting with the pills and they go to heroin. Why? Because they can't afford the pills anymore. And they need more of them and more of them and more of them just to not get dope sick. They're not even trying to get high anymore. So the tolerance is something that happens to everyone. And when we say dope sick, those are the withdrawal symptoms. So, and we're going to talk at length about alcohol and heroin and opioids, because they're the big ones, the big ones in this country. People that are addicted to opioids, they will do anything to just get the minimum amount they need to not get dope sick, because dope sick is the sign of withdrawal, nausea, vomiting, diarrhea. I mean, they will literally feel like they're dying. They won't die though. So withdrawal from opioids will not kill you. And oftentimes people that have substance use disorder are always saying, I got to stop this. I have to quit. I can't keep doing this. But they don't. for various reasons. Sometimes they'll give up important activities secondary to the drug use. And even though they know that it's causing problems, even with their relationships, families, job, whatever, they will just keep doing it. They waste a lot of money, right? And a lot of time. And sometimes there are other behaviors that go along with it, but not always. But sometimes, combine overuse of substances with other compulsive behaviors. So, not often, but sometimes you'll see people that live kind of on the edge or a little recklessly, right? Sometimes that goes hand in hand with drug use, but not always. When we talk about recovery, so they can be active, they're in recovery, which is actually actively in recovery. And I just want to tell you that once someone is in recovery, they are always in recovery for the rest of their life. So in other words, when someone gets clean, that day that, once they get clean, they are always in recovery till the day they die, right? So it's not something that's temporary. And they can be on some type of a medication to help them along, right? Or they can be in a rehab or some type of a controlled environment. And there are lots of different facilities now for people with substance use disorders that they can, get help. Most scholarly resources believe there's a hereditary component to this. Like I said earlier, you'll see it run in families, and it's not a coincidence. There are also theories that, emotional and psychological theories. We all have something called our stress tolerance limit, right? Every human being has that. And that means that each of us has this kind of unspoken limit in our brain of how much stress we can take until we go. Some people can take a lot of stress. Some people can take only a little bit. Most of us are kind of in the middle, right? We can take a reasonable amount. But for some people, when they hit that stress tolerance limit level, it can drive them to, like I said, either drown the problems away with alcohol, or, I don't want to think about it. I'll just take some drugs and not forget. And it can start out just as a temporary thing, and then it can become problematic over time. I will tell you this statistically, and we can look this up so I can prove myself. People that take opioids or narcotics for actual pain, okay, less than 1% of that population becomes addicted. Less than 1%. So, it's not accurate to say that, oh, you have pain, you were in a terrible car accident, you broke 10 bones. Don't take Percocet because you'll be buying a bundle on back Maryland next week in Atlantic City. Not accurate. It's not accurate. If you're taking pain meds for pain, that's why there are pain meds, right? And the idea is to kind of titrate down, over time. The pain starts to get less, you lessen the amount of drug. So a lot of people have dual diagnoses. So a dual diagnosis facility is one that covers both psychiatric diagnoses as well as addictive or substance use disorder diagnoses. A lot of times people that have psychiatric diagnoses will self-medicate. They know something's not right, and maybe it's because of the stigma, they don't get help, or for various reasons. So they will take illegal drugs or alcohol to quell whatever's going on psychiatrically. So that's not uncommon. It's actually very common. That's just a really groovy little picture. I mean, let me make it a little bigger so that we can all enjoy it. And it's got this naked lady in the middle with mental illness and substance use disorder. So we're looking at the dual diagnosis, and then all these things that are potential factors, right? Violence, loneliness. Let's throw AIDS in there. Not HIV, just full-blown AIDS. Homelessness, education, infections, abuse, prostitution, vulnerability, poverty, alcohol, drugs, medication side effects, physical illnesses, unemployment, crime, money, malnutrition, psychiatric symptoms, family problems. So there are, drug and alcohol use disorder. Gotta stop saying addiction, not PC. Is multifaceted and multi-layered. It is not, there's no simple explanation for it, right? So, we do a terrible job, in my own humble opinion, does not reflect the opinion of AHA schools nor any of its affiliates. In this country, we don't do a great job because arresting people and putting them in jail is not helping. It doesn't help anybody. It doesn't help them, and it doesn't help the system, and it certainly doesn't help their families. People need cognitive behavioral therapy, psychotherapy. They need help. They don't need jail. And this is something that I guess we haven't really gotten the memo just yet on how to manage substance use disorders in this country. And it does have a progressive nature. In other words, in the beginning, it's like, I'm just doing a couple lines of coke because it's cool. And then the next thing they're spending all their money on coke. Coke's expensive, if you guys know that. I worked at Recovery Centers of America. It used to be called the Lighthouse. I worked there when it was the Lighthouse years ago. And I would have people come in that like lost their car, their house, their family for coke. And I would think, I mean, I don't know. I don't know. I don't get it because it's like such a short high and so find something better for your addiction than cocaine. That's not a good one. But anyway, they will start out to party and then now I want it. I want more and more and more and more. And then they lose control. And that happens with other substances too, right? Sometimes even with alcohol, they'll have a drink to just, I had a rough day. I need a drink. And that can escalate to even more than that, then especially with the opioids. The opioids, this is where this second one becomes really important because they need it to just not be sick. They're terrified of being dope sick. And they'll use defense mechanisms sometimes like deny. I don't have a problem. What are you talking about? I'm fine. Rationalization. No, I need it. I need it, And sometimes they'll project, well, look at you. What do you do? Right? Don't worry about me. Worry about you. In order for them to get help, there have to be a couple things that have to happen. Somebody's got to recognize there's a problem. Someone has to intervene because sometimes the person, won't do it. And interventions can be all types of interventions, but, most people need support and something structured, for the withdrawal part of it. And then also just moving on with their life as a recovered, substance abuser or user. And there are lots of different types of therapies out there. Is the following statement true or false? A nurse should ask assessment questions concerning the family history of substance use to help determine the risk factor of possible genetic causes of substance use disorder with the client. It said false, but I changed it because it's true. When you're doing an assessment on a patient, you always want family history. It's important to have a comprehensive family history because there are many things that do run in families, not just physiological things, but psychiatric diagnoses. Schizophrenia runs in families. Depression runs in families. So it stands to reason, like I said, that substance use disorder runs in families. Okay, so you always ask about family history. So what do we do for these people? Nursing care. Lots of different types of settings. There's outpatient, like IOP, intensive outpatient therapy, extended care facilities. There's withdrawal. People can go into, inpatient detox. This is their statement. 1/3 of ED admissions and 1/5 of acute hospital admissions can be traced to complications related to substance use disorder. I will not validate that statement until I look it up, but I'm not sure that it's true. Anyway, moving on. So identifying somebody that's got a problem, substance use disorder. Oftentimes you'll see people that will come into the emergency room, and I worked at ER for 20 something years, and they will come in, and it's funny because people that were drinkers would minimize when you would ask them, do you drink alcohol? How much do you drink? Oh, weekends, maybe a drink or two. But people that would take pills would maximize the amount, right? And this is just in my experience, but I did find some research on it. Why? Because if they take 6 Roxys a day, they're going to tell you they take 10 to make sure that you give them at least enough so they don't get sick. Does that make sense? Right? And you always want to be alert for signs and symptoms of either substance abuse or withdrawal, because withdrawal for some substances can be dangerous, life-threatening. Alcohol and benzos. Withdrawal from either of those things can kill you. So, and we'll talk about that in a minute. That's important to know. So you want to make sure you're really assessing the patient, neuro assessment, look at their eyes. Are their pupils dilated or are they fixed and pinpoint? Try to always be non-judgmental. There's one thing that I can't stand, and I used to see it in the ER a lot. We are not here to judge anybody, and we're not supposed to do a 500-yard conclusion jump about anybody, right? Don't do it. So he's drug seeking, she's drug seeking. Come on. Let's give it a minute and let's see what's going on with this patient before we do that huge 500-yard conclusion jump. It's not right, it's not fair, and it goes against the very ethics that we're supposed to be following as nurses. Okay. You want to ask as many questions as you can, and you want to try to ask open-ended questions. Oftentimes, they're not going to tell you the truth. And, it is what it is, but you do your best to try to, get as much information from them as you possibly can. You always want to stay with somebody, especially if you suspect that they may be going into withdrawal. And again, especially when we're talking about benzos, we're talking about alcohol, those two things. We talked about in the previous video in chapter 94 about restraints. That's the absolute last resort are restraints. You don't want to tie any. Would you like to be tied up? No. So says here, don't touch the client unless absolutely necessary. Just use your clinical judgment, but I wouldn't say don't touch the client. I'm getting rid of that. I don't like that. Right. Away. There we go. And of course, if you need help, get help. But, if you stay calm and talk to the patient in a very calm way, most of the time, everything will be fine, right? But if you get like, oh my God, I think he's on drugs with it, and turn into a Karen, then yeah, you might have a problem, but you can incite that behavior in somebody. They want to have a cigarette. No, you're not allowed. Really? Let them have their cigarette. Like you're not a jail keeper, right? Just be calm, cool, and collected. There's many de-escalation classes. I've taken a few where dealing with somebody who could be actively intoxicated, sometimes they get a little aggressive. There's an old expression, beer balls, right? And sometimes they have a few too many drinks and I'm gonna fight everybody in the bar. So you want to, the more calm you remain, the better off the situation can be. When you bring them into the emergency room, depending on, especially if the police bring them in through a PIP because they're acting aggressively, we're going to do a toxicology screen typically. That takes time. Tox screens are not quick. So we want to know exactly what drugs are they doing because they're not probably going to tell, right? But tox screens usually take a minute to run. You want to make sure that you're asking them questions, but they may not answer you. When it comes to alcohol or benzos, it's super important to try to find out when the last drink was or when the last Xanny or whatever Xanax was, right? Because there's a time frame, and we're going to get to that, associated with withdrawal symptoms, okay? You're going to look at their physical behavior, yada, yada, yada. It's always the nursing process. You always have to assess before you can diagnose, and then you plan, and then you implement, then you evaluate, right? Is the following statement true or false? A person's frequency of drug use is the best criteria for determining whether they have a substance use disorder. Yeah, how often and how much a person drinks or uses drugs is not always the best criteria. It's really this one I agree with. It's the role that substance plays in their life. How important is that versus their family, their career, and other things, right? That's really, and have they lost a wife or a husband because of it? Are their kids not speaking to them because of it? Like lots of other things that are far more important. So the first step is always detox, right? Because we can't, think about Maslow's hierarchy. We have to deal with physiological needs first before we can even get to the psyche, right? So you want to make sure that we detox them safely. And we're going to talk about what a safe detox looks like. What motivates people to get treatment? Court, that'll motivate you. The judge says, go to treatment. That'll do it. But sometimes people realize they have a problem and they want to stop. And sometimes they just need either an intervention from their family, their friend, something to kind of push them and say, hey, listen, don't you think enough is enough? It's no kind of life, Yeah, so rating scales, again, with the standardized scales that we have. The CIWA, which is the Clinical Institute Withdrawal Assessment Form. There's one for opioids. This one speaks to alcohol. And it gives a rating, of the different behaviors and manifestations that you'll see in somebody in withdrawal to how severe the withdrawal is. And are they at risk for delirium tremens, the DTs, seizures, that kind of thing. Okay. So, and long-term treatment, we can't just detox them and then send them on their merry way. Go back home, go back to the same environment that you were in, and everything will be fine. That's ridiculous for us to think that, but we do it all the time. They need some type of long-term counseling. And oftentimes, like I said, there are past traumas. There's usually something else that's motivating people to behave like this, to engage in substance use. And it's not just because they feel like ruining their life. There's usually a reason. Okay, alcohol use disorders, first one. So what does somebody look like when they're drunk? Alcohol is a central nervous system depressant. Even though with the first shot, you're like, whoa, but by the third shot, you're like, right? Or the fifth or whatever tolerance you may have. But slurred speech, unsteady gait, confusion, sometimes aggression, behavioral changes. People that drink are very identifiable. They are very identifiable. The swollen nose, if anybody ever heard of W.C. Fields, if not, look him up. W.C. Fields. He was a comedian way back when, like in the 30s, right? And he just had this big bulbous nose. You knew he was a drinker. Rhinophyma. And that rhymes. Cool word. Rhinophyma. That's that swollen bulbous nose. They'll get spider angiomas, these broken blood vessels on their cheeks and on their abdomen, which, by the way, is swollen because they have a beer belly. But that's it, the medical term for a beer belly is ascites, abdominal ascites. It's fluid that's trapped in the peritoneal cavity, and it's as hard as a rock. It's not fat, right? Sometimes they'll have palmar erythema. Their palms get red, right? Impaired attention, confusion, amnesia, the blackouts. Did you know what you did last night? No, what? What'd I do? Right? They will have no recollection. Sometimes psychotic symptoms and sometimes suicide. Suicide is a risk for any drug or alcohol, right? So we talk about how we test for alcohol. So we can do breath testing, just like the police do, right? Little thing, blow into it, and it can check your blood alcohol level. The legal level, 0.08, right? That's the not 0.10. So here in New Jersey, let's get rid of that. That's the level, okay? Once you get to these higher levels, you could be in bad shape, right? So when someone passes out, when they've had too much to drink, depending on how long they've been drinking and what type of tolerance they have, these are all variables that have to be considered. Somebody may have too much to drink, and that might mean 4 drinks for that person, right? Whereas another somebody having too much to drink might mean a bottle of vodka, right? So the outcome can look very different for each of those two people, right? The person that had the 3 or 4 drinks and they're lightweight and they never drank before, and they pass out and maybe wake up and throw up and I won't ever do that again, right? Versus the one that drank the whole bottle of vodka, they may slip into a coma. There are lots of concerns about someone who drinks that amount, okay? Because it can lead to coma, respiratory depression, and even death, okay? So what are we looking at? We're going to look at their liver function, right? And their enzymes. So let's just put this here so everybody knows. We're going to look at AST. We're going to look at ALT. We're going to look at bilirubin. Okay? It's all important because drinking damages the liver. And the liver will get to a point where it will develop cirrhosis. Cirrhosis is where a portion of the liver literally gets hardened, right? So that it can't function properly. And with people that drink, they can develop hepatic encephalopathy. What does that mean? Well, the liver gets so damaged that it allows ammonia, which starts out being ammonium, and it's typically filtered by the liver and excreted in the feces, right? When you have damage to your liver, it can't do that. So it will spill that ammonia back into your bloodstream. It crosses your blood-brain barrier And it will cause changes like you read about, like the people will be aggressive, combative, disoriented. They'll come in wanting to fight everybody. They don't know who they are. They don't know where they are or why they're there. It's bad. And the treatment, believe it or not, for this, and let's add that here, the treatment is good old lactulose. Lactulose is an osmotic. Oftentimes you'll see it in nursing homes used for constipation. It will give you some diarrhea, but the real indication for lactulose is to decrease ammonia levels in the blood, and it's given as an enema. Doesn't that sound like fun? So when it gets into the colon, because it's an osmotic, it actually attracts ammonia through the wall of the intestine, sucks the ammonia out into the poop, and then they have diarrhea. So you'll treat them, and then a few hours, you'll see the levels, ammonia levels start to go down, and they'll literally be like, who are you? What am I doing here? What happened? No recollection, right? And we'll give them the speech about, oh my gosh, you don't want to do that again because that was a little dangerous, but they probably will do it again. And there will come a point in time where if they do it enough times, it can be irrevocable. We can't fix it. The lactulose will just not work because the damage to the brain has become permanent. So it's very important to understand this. Okay. Alcohol is a dangerous thing. It is. When people drink on the regular, sometimes they don't eat. That's a big thing. They'll drink their breakfast, they'll drink their lunch. They'll wake up in the morning and they will be shaking so badly that they can't even think about eating anything. That's the DTs, delirium tremens. And we'll talk about that in a second. But they'll be shaking so bad that they will need a drink, not want one. They'll need a drink to stop shaking, or they won't be able to function. And they typically will have deficiencies in thiamine, folic acid, folate. It's the same thing. Right. And you'll see that they will typically give 1 milligram of thiamine, 1 milligram of folic acid to everybody that's got alcohol use disorder, because they're always deficient in that. Having thiamine deficiency can cause something called Wernicke-Korsakoff syndrome, okay, which is also what happens with that hepatic encephalopathy. There's the part of your brain, the Wernicke's area, that has to do with your ability to reason and understand things like executive function, right? And it becomes damaged. They used to call it wet brain, right? From drinking. And they look like someone who's got end stage dementia, right? Dementia, diplopia, double vision, ataxia. They kind of have this weird shuffly kind of gait. They can't really lift their feet up. Somnolence, right? Stupor, and horizontal nystagmus, which is fun to watch, but it's bad for the patient. It's where their eyeballs go ding, 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 back and forth like a pinball machine, right? Cirrhosis of the liver, and oftentimes cirrhosis of the liver doesn't just lead to liver failure, it can also lead to liver cancer, which is in and of itself a good time, right? Other things that can happen when people drink: esophageal varices. They are dilations of the veins in the esophagus, in that smooth lining. Because alcohol, when you took your first drink, you didn't go, it tastes like pudding, right? You were like, bleh, right? Everybody's like, oh, it burns. Well, keep doing that all the time. And eventually they don't feel the burn anymore because it's starting to erode the inside of the esophagus. And that can cause this dilation of blood vessels. They can come in, and I've seen this twice. They come in and they're just blood, fresh, frank blood, not like a GI bleed where it's coffee grind emesis. No, blood. And in a pinch, we stick a Foley and inflate the balloon down the esophagus, and that'll put pressure to stop the bleeding temporarily. It's an old trick. The guy that used to run the ER in Atlantic City, old Charlie, he taught me that trick. He was a good nurse. Anyway, but you can die from esophageal varices. They can wind up with different types of cancers, not just liver cancer, cancer of the mouth, the esophagus, gastritis, gastric ulcers. It messes up your kidneys. It'll screw up your heart because everything in your body is connected, right? And if one thing isn't right, something else won't be right, right? So, and if you're pregnant and you drink, fetal alcohol syndrome, FAS, looks just like Downs, looks just like trisomy 21. Okay, and it's permanent neurological damage. Treatment, detox, the drug of choice, and this is something you need to know. It is a benzo that we give them, chlordiazepoxide. Make sure you know that drug. They will ask you about it, the board. Okay, chlordiazepoxide. It is a benzo, and it's specifically used for alcohol withdrawal, right? For detox. And what we do is we will give it to them so that they will not have the DTs and seizures. And then we will titrate them down over the next 72 hours. That's the magic number for alcohol. So when someone's a true alcoholic and they drink every day, all the time, 6 hours after, and this, you need to know this because there are questions about this, 6 hours after their last drink. So between 6 hours after their last drink, that's when these manifestations can start. A little bit of shaking, starting to feel a little shaky and get progressively worse and worse and worse and worse. That's the delirium tremens, or the DTs, they call them. And that will get worse if they don't get something in them to stop it. And it can lead to seizures, full-blown grand mal seizures, coma, and death. So drinking, detox from drinking, can kill you. Okay. And the magic number is that 72 hours. That's where you're, 6 hours and 72 hours. That's the window of time. Right. And so usually by the fourth day, we will have titrated them down off of the chlordiazepoxide, and they're usually feeling better. But they need a lot of help. Like the first day, 2 days, they're shaking so badly, they can't hold their phone, even if they wanted to. For real. They can't even eat. It's like try to get something in their mouth. I've seen it. I mean, and I worked a night shift back then, so I saw all kinds of stuff. It's very dangerous. And the other thing is sensory or perceptual disturbances. Tactile hallucinations are common in alcohol withdrawal and benzo withdrawal. They're bugs on. Where are these bugs coming from? They will feel like bugs are crawling all over them. There's nothing there. So these are all withdrawal symptoms. So now we get you through the detox safely. No seizures, you're not dead. Okay. We'll talk about this in a minute. But then what do we do for the long term? Because we can't just go, okay, you're good now. See ya, and send you home. So for the long term, we can do a couple different things. We should always have them participate in some kind of outpatient, at least, therapy, whether it's a 12-step program like Alcoholics Anonymous. I mean, it could be, there's multiple types of treatment out there, but there's also medications. And this one, the Board of Nursing loves this drug, disulfiram. Okay, it's also called Antabuse. That's the trade name. Disulfiram, when a patient takes it, if they even get near alcohol, they don't even have to drink it. If they just get near it, if this were alcohol in this cup and it were just sitting there that close, I would be like, oh, oh. They will throw up things they ate in kindergarten violently, puke. All right. And the idea is it's a negative conditioning. Okay. Once I take you off of the drug, your brain will associate alcohol with throwing up. And hopefully that will be a lasting sensation. So even without the drug, you're not going to want to be near alcohol. And by the way, this includes antiperspirants, mouthwashes. There are many things over the counter that contain alcohol. Lotions. You got to make sure you read labels because most of them contain a form of alcohol. So, and any of that will make them throw up, like I said, and it's not cool. It's bad. All right. It's the one you need to know. The naltrexone, I mean, Vivitrol, some of the fancy schmancy places are using that too, long term. But disulfiram, as long as they don't get near the alcohol, because it's miserable when they're throwing up like that. This third thing here, kudzu, which is a plant. It's a holistic treatment. I don't have any information on that, and that's not one of the treatments that the board talks about. The board will ask you about ginger and ginkgo biloba and chamomile and valerian. We'll go over those later, but this is not on the list. So Don't worry about it. So to backpedal to here, they talk about family considerations. Oftentimes with alcohol, either somebody in the family is codependent or somebody is the enabler, right? So in other words, they're like, well, I know he drinks, but he's got it rough. He works a lot. He deserves it. They'll make excuses and on all types of things. It's important if there's a family involved that everybody gets some type of treatment or it won't work. Everybody's got to be on board, right? And there are plenty of treatments out there that include the whole family, right? All right. Next, substance use: sedatives, hypnotics, and anxiolytics. Back in the day, like when Elvis was king, not you, the other guy, Presley, right? They found him, he died on the toilet. Embarrassing, right? Embarrassing. He was so handsome when he was young, but as he got older, he had barbiturates to go to sleep and speed amphetamines to wake up. And he got all bloated and he didn't look good. It's a sin. Anyway, but when he died, we all cried. Everybody was out in the street crying, Elvis is dead. Anyway, so barbiturates were a big thing back then, not so much now. The big things now are the benzos and the opioids, right? They're the big ones now. Benzos, alprazolam, Xanax, diazepam, Valium, lorazepam, Ativan. But Xanax, Xanny bars, right? That's a big thing now. So Xanax, alprazolam, is dosed 0.25 milligrams, quarter milligram, half a milligram, 3/4, up to 1 milligram. The alprazolam bars are much higher doses. They are 1 full milligram, 2 milligrams, 3 milligrams. That's a lot of alprazolam. And if someone's taking that on the regular, any benzo, they can't just stop cold turkey. So if you're taking a benzo regularly for more than about 3 months, you can't just stop because it looks just like alcohol withdrawal and has all those same symptoms, the tremens, the seizures, possibly coma, possibly death. So you have to be titrated off of the drug a little at a time, right? We have to wean you down. And that'll usually be in a controlled environment, like in a detox facility, right? They call it cold turkey. That's what they call if you just stop something suddenly. It's called cold turkey. I don't even know where that expression came from, but I'm going to look that up as soon as I'm done this lecture. GHB, the date rape drug. Know of people being addicted to GHB. I've never read any scholarly articles about it. You can be addicted to anything. So this one they call it liquid ecstasy. It is like it's a hallucinogenic, right? So and the withdrawal is similar to alcohol or benzos. So I wouldn't worry too much about that one. Marijuana, cannabis use disorder, symptoms of misuse, a dreamy state. Well, that sounds nice. Euphoria, I'm happy. Impaired motor coordination, impaired attention, judgment, tachycardia, anxiety. They don't have paranoia? I mean, that's the big one, right? Who's out there? Who's looking at me while I smoke? Paranoia is a big one, and dry mouth, of course. But again, it is now legal, both medicinally and recreationally in this state. So, but you can still have a problem with it. If it's more important to you than paying your bills or taking care of your family, then you may have a problem. So it's just something else to be aware of. People that withdraw, if they're consistent pot smokers, marijuana users, they can sometimes be just really lethargic and kind of, they can be irritable, little uptight. Usually takes about a week. The THC, the active ingredient in marijuana, has a long half-life and it clings to lipase tissue in your body. So if you have, some extra fat tissue, it hangs on longer than it would in the average person, right? So a week, sometimes 2 to 3 weeks for people to go through like withdrawal if they stop using it. Again, moderation is the key to life with almost everything. So opiates. Here's the big one now, opiates. And it includes all of the opioids, which are morphine, codeine, Heroin, which does not have a medicinal use at all. Oxycodone, hydrocodone, hydromorphone. Methadone can even be a problem. Butorphanol titrate. Vicodin is just the, hydromorphone, Percocet and Vicodin, or hydromorphone or oxymorphone with APAP, which is acetaminophen. Right. So, most people aren't addicted to the Tylenol part of it. They're addicted to the hydromorphone or the oxymorphone part. So this is one of the big problems. So with the opioids, again, heroin should be at the end of the list because people don't start off going, you know what, I'm gonna bang some heroin today. Let me go get some. It starts off with something different and then it kind of escalates to that. Or they can certainly be like kids, like, oh, come on, we're all doing it. You do it. I had a friend who was snorting heroin and then, graduated up to banging it. And she did get clean, so which was a good thing, but she was in bad shape for a while. What are the symptoms? Dope nodding, right? If anybody's ever seen anyone that's on heroin or any of these opiates, still, kind of eyes closing, not because they worked the night shift last night, not because of that. So opioids are central nervous system depressant, right? So when we talk about any type of withdrawal, remember, any drug or substance that depresses the central nervous system, withdrawal symptoms will be the opposite. Just keep that in mind. So cannabis, alcohol, benzos, hallucinogenics, almost all of those, and opioids, all are central nervous system depressants. So you're going to be like this, but then when you are going through withdrawal, you're going to be anxious and irritable, tachycardic, blood pressure will go up, right? Vomiting, nausea, vomiting, and diarrhea. I've seen patients curled on the floor, just shitting their pants and vomiting and just crying. Opioid withdrawal will make you feel like you're going to die. And I've heard people pray to die, but you won't die. You just feel like you're gonna. Whereas alcohol and benzo withdrawal, you can die. Okay. And what is the treatment for overdose? You need to know, of course, naloxone. Make sure you know that one. Narcan. And it's important to know naloxone has a short half-life. So if you administer a dose of naloxone to someone in respiratory arrest, because that's what kills them, right? They go into respiratory arrest. The respiratory rate goes so low that they stop breathing. Then the heart stops, but the breathing stops first. You give them naloxone, you give them Narcan, you want to make sure that you're calling 911 because you don't know what they took or how much they took. And they may need 2 doses of Narcan or 3 or 4. And the other thing that's important is it is an opioid antagonist. So it blocks the receptor sites. It pushes the opiates out of the way and then it gets on the receptor sites and won't let the opiates touch the receptors. If they had pain before, they're going to have a lot of pain and they will sometimes wake up and want to fight you. So keep your distance, right? And call 911 every time because you just don't know how much they're going to need. And they may wake up, want to fight you, and then boom, stop breathing again. And if you don't have a second dose to give them, right, everybody's in trouble. Okay. Long-term help with people with opioids. Methadone is the old school kind of drug. There are methadone clinics. I have actually seen people go up to the window, get their dose of methadone in a little cup, put it in their mouth, swish it around, spit it back in the cup, and sell it to the guy over here. Swear to you. I was like, oh. Yeah. So, because it binds to opioid receptors. Right. So you're going from being addicted to heroin or Roxy's, you will be addicted to methadone. It was originally started, you were supposed to be titrated down and off of it gradually, right? To help you, lose the addiction. Now, I mean, again, this does not reflect the opinion of AHC schools or any of its affiliates, but they make money if they keep you coming back for more methadone, don't they? Anyway. And then Suboxone. Suboxone is the big one now. Looks like Suboxone, but it's pronounced Suboxone. It's a combination of buprenorphine and naloxone. So in other words, it will bind to the same receptor sites, give you a little bit of a high, but not too much, keep you not get sick. You won't get sick. And people are on this indefinitely, which I don't believe was the initial. I mean, I'm not sure what the initial point or premise was, but you'll see people on Suboxone forever and a day. And Revia, which is now Trexone, which is kind of like naloxone, binds to those same opioid receptors. Okay. So that's, agonist and drug replacement therapy. All right. Next use disorder would be stimulants, amphetamines, crystal meth, Breaking Bad. So so cocaine and methamphetamines and amphetamines are all forms of stimulants. So these are central nervous system stimulants or uppers. So they make you like, everybody's all happy and everything. Withdrawal from these is the opposite. They're going to be lethargic, tired, just no motivation, just apathetic, et cetera, et cetera. But while they're on it, they're going to be, blood pressure is going to be elevated, heart rate's going to be elevated, pupils are typically dilated, muscle weaknesses, sexual dysfunction for sure, sleep disorders for sure. I hear comedians talk about, yeah, we did an 8-ball of Coke and I'm laying here and my heart's getting ready. I think tonight's the night. This is the big one. That doesn't sound like fun to me anyway. And people that use meth, sometimes you can tell if you ever go to Kensington in Philly, they have a lot of people on meth and on opioids. They will pick, and they will have just marks from head to toe. They will pick and scratch their skin. They'll be paranoid. Sometimes they'll even get delirious depending on how much they took. And you don't know again, when you're buying drugs on the street, good guess as to what's in there. A lot of people are overdosing when they're buying heroin because now it's laced with fentanyl. And fentanyl is about 1,000 times stronger than every other opioid. Fentanyl's dosed in micrograms. All the rest are dosed in milligrams. So there you go. So that's a big problem with a lot of these drugs. It's like, what are you going to do? Hey, you sold me bad drugs. I want my money back. That doesn't work. And yeah, so with methamphetamine withdrawal, just like with cocaine withdrawal, they're usually tired, sleepy, and just apathetic, right? Sometimes they'll use other drugs, like if they can't fall asleep. In rehabs, we'll give Benadryl. They'll be like, can I get a sleeping? No, you cannot. No, you cannot. Here's cocaine. Very dangerous. When you're pregnant, anything you put in your mouth, anything you put in your body, the whole time goes to the baby. And the first trimester is when the baby's neurological system is starting to develop. So you can cause a lot of damage. So either use birth control, public service announcement of some type. And I mean, if you want to do it to yourself, I feel bad, but don't bring another person into the world and make them suffer, just don't do it. Cocaine, same, but like methamphetamine, woo, party, But again, withdrawal, it had said that withdrawal from this was deadly. No, it's not. Withdrawal from cocaine and methamphetamines and amphetamines all are pretty much the same. They just want to sleep, right? They want to sleep. It's the opposite of the action of the drug. So just keep that in mind. Whatever the drug does, withdrawal is the opposite. So they want to sleep. They're lethargic. Okay. Hallucinogenics like mushrooms, LSD, mescaline, all of those. They're even microdosing now, a lot of these drugs for people with like PTSD as a treatment modality. My opinion, again, I have a lot of opinions and I want you to hear all of them. With these, if you have a drug that I'm going to flash back and even after I'm not taking the drug, I'm going to feel effects of the drug like in a year or two. It sounds like a good bang for your buck, but no thanks, because these things can really alter the brain function. All hallucinogenics can alter, and permanently over time. So they're dangerous. All my friends used to do shrooms when I was in high school. I was like, no thanks. What's the matter? You're scared? No. No, but I like my brain the way it is right now. Thanks. I'll just keep it the way it is. It's good. They can have trips. They can have bad trips. People have there was a guy named Art Linkletter. Here, you'll show you my age. He did a TV show like in the 50s with little kids, like kids. It was almost like Kids Say the Darndest Things, like that kind of a show. His teenage daughter threw herself off of the roof of a 28-story building in like 1969, I think, or 68, something like that. She was tripping and she was having a bad trip on LSD. So bad drugs, don't do them, right? Phencyclidine hydrochloride, also a hallucinogenic. Bath salts, that was a big thing for a while. I don't think it still is, but inhalants, people can huff gasoline, right? Which they can do whippets, which is whipped cream containers, right? There's a gas in there, right? That makes the whipped cream come out. It's a nitrous, like a nitrous oxide. They will just suck out the gas and get high from that. It can cause permanent brain damage. I mean, smoke a joint, if you got to do something. This stuff's dangerous. Really, really dangerous. Steroids. Now, we're not talking about cortico or glucosteroids, glucocorticoids. We're not talking about methylprednisolone or dexamethasone. Here, we're talking about anabolic steroids. So these are the drugs, the enhancement drugs that oftentimes athletes will do and they'll get caught doing. It will make them, I want to get big. Let me bump you up. Right? So the problem with these are testosterone, right? It's the male, like they're androgens, male hormones. So they have no neck, like this. Their traps are here, no neck. And they will be subject to something called roid rages, okay? And also testicular atrophy, which I wouldn't sign up for if I was a man. If my testicles were going to shrink, I might be a little worried. But anyway, okay, good luck. So you can usually tell when you see those big, they're like super big, jacked, like muscle bound, right? No neck guys. Sometimes they're doing the juice, they call it, and they do it via injection, right? These steroids, anabolic steroids. It will make them big. They will get jacked up muscle mass. It builds muscle mass super, super fast. But what it will do, here's all the side effects: roid rage, testicular atrophy, liver damage, cancer. Remember, testosterone, when we're talking about hormones, estrogen, female cancers, testosterone, male cancers, endocrine sexual dysfunction, impaired judgment, electrolyte imbalances, acne. That's another telltale sign. They will develop acne. Sometimes edema, headache, fatigue, insomnia. Withdrawal is difficult. I don't know what that means, but so we're going to get rid of that. I don't like the way that's written. Mood lability. To be labile means to be up and down, right? Somebody is labile, emotionally labile. That means that they're up and down. They're happy, they're sad. They're happy, they're sad. They can be paranoid. They can be depressed. They can even be suicidal. And they can die from endocrine imbalances. You can't mess around with the hormones. It's a dangerous thing. And it can throw them into some very, very weird, different types of endocrine imbalances, especially when it affects the adrenals, which affects the kidneys, which affects the blood pressure and the heart. You can have a heart attack. The list goes on and on and on. So they're just bad, right? And during withdrawal, they can really get angry as the feeling starts to wear off. Very, very angry. That's when you'll see that roid rage. They'll want to fight you. What do you mean I can't have a glass of water? Bam, they can be dangerous. So just be aware of that. Never turn your back on any patient if you ever are in a position where you're dealing with a psychiatric or a dual diagnosis or drug or substance use. Never turn your back on them, just to be safe. Don't be scared, but don't turn your back. Like when stay with your back so this way you're walking out and you know what's going on, just in case. All right. Oh my gosh, cigarettes. Jeez. Shh. Nicotine is bad for you. Yeah, I guess it is. Causes cancer. Cancer of the lungs, the lips, the mouth, and the throat. And think about it. Nicotine is not just cigarettes. It can be chewing tobacco. If you ever see, like, especially like baseball players, they'll have this thing in their, no, and they'll spit. It's pretty gross, actually. You ever look at their teeth? Their back teeth, they're like rotted. So don't do that. That's gross. It causes all types of cancers, stomach cancer, kidney cancer, pancreatic cancer. The list goes on and on. It also, just so you know, nicotine is a vasoconstrictor. So if somebody's going in for surgery and they're a smoker, the doctor's going to say, hey, lay off the cigarettes at least for a few days prior to the surgery, right? And of course, you know, lung cancer is the most common thing, and COPD. E-cigarettes, we don't really know the long term of this because they haven't been around long enough for us to really know. But with vaping, they can be vaping marijuana or they can be vaping nicotine, you know. It's water vapor that they're inhaling, but you're still getting the nicotine, and we don't know what the water vapor does to the lungs either. So that's still up in the air. Okay. Caffeine. And here they're talking more about like overuse of caffeine, like Red Bull, you know, or those energy drinks that are out there. You can give yourself a heart attack if you use too many of those, right? Or caffeine pills. Back in the day, in the backs of magazines, and I'm talking in the late 70s, like 78, 79, and 80, you could buy pink crosses and black beauties. They were just caffeine pills. You could buy 1,000 pills for $5. True story. So you, again, addiction or disorder, substance use disorder can be many things. Oftentimes we'll use coffee to keep us awake. You know, maybe we've got, you know, we worked all night trying to stay awake, but you know, it does have value when it's used correctly. Fun fact about caffeine, it's a bronchodilator. If somebody's having an asthma attack and they don't have a rescue inhaler, tea or coffee, quick, strong. It's a bronchodilator. Right. So fun fact. Yep. But overuse can cause jitteriness and restlessness and tachycardia and And also overuse, and it doesn't say that here, but it can have an effect on GI discomfort. We're talking about like gastric or peptic ulcers or erosions in the esophagus too from too much caffeine if you're drinking a lot of coffee. And Starbucks is expensive. Over-the-counter drugs and herbals. I'm going to throw this in here about the nasal spray because that's important to know, okay? I'm going to say nasal spray. Oops. Thank you. Nasal sprays. So people can be addicted to Afrin. I know it sounds crazy, but it's true. Nasal spray. And what will happen is when they stop using it, they'll get rebound congestion. So make sure you know about rebound congestion. You can't just stop. So if you're every day, you want to stop one nostril first because that's going to get stuffed up. But at least you got this one that's still good. And then you're going to wait 3 days, 4 days. And then once that congestion clears up, then you'll stop the other side. Okay. Herbals are dangerous. Cocaine grows as a plant, right? So just because something is natural doesn't mean that it's safe. Yeah. Cocaine grows as a plant. Look it up. So people are like, oh, it's herbal. So it's okay because it's herbal. That is not true. So most of the herbals are contraindicated if you are on cardiac meds, anticoagulants, antiplatelet aggregators. You got to be super careful with these supplements. Valerian root, ginkgo biloba, ginseng, garlic. Any supplement that's an herbal that begins with a G will make you bleed. There are others too, chamomile, right? So you got to be super careful. I will make a video of all the herbals and all their side effects too that you need to know, but that's coming next, okay? So herbals can cause problems. Following statement, true or false? Herbal and dietary supplements can cause medical conditions. True, right? Sometimes they have beneficial effects. I don't know about that. But at any rate, they can be dangerous too. If you're pregnant, like I said earlier, just please don't do drugs. Kids, adolescents, I mean, you know, people sometimes will do it because of peer pressure. They want to be part of the group, especially kids, right? I tried to teach my kids that from a very young age, like, don't care what anybody says or thinks, right? Don't worry about it. Alcohol use is actually right now not on the rise, but the vaping is still kind of, a big deal with the younger population. But again, we don't know the long-term effects of that either. For older folks, believe it or not, this is true, prescribed and over-the-counter meds. Sometimes they'll take, like if they have, we call it agita, they have heartburn, gastroesophageal reflux, they'll take a Tums and another and another. You have to follow the instructions on the labels of these over-the-counters. Calcium carbonate, right? So most of these over-the-counters that have to do with GI are either calcium, aluminum, or magnesium. Okay. And all of them will throw off your electrolytes if you take too many, right? Think about milk of magnesia. What does that do? That's for constipation. It's a laxative, right? When you take magnesium, it's going to wind up giving you diarrhea if you take too much. So you got to be careful. I've had patients come in with electrolyte imbalances, come into the ER, and they'll say, well, I was just taking some Rolaids. Yeah, but you took the whole pack. Like, don't do that. Remember, the very old, the very young, most fragile, right? Nurses. There are drug diversion problems. Believe it or not, nursing's a little stressful. Did you know? Just a little, not much, just a tad. And some nurses, because they have access, sometimes they have drug problems. You are bound by law to report somebody. If they're taking care of patients and they're impaired while they're doing it, I'm not all about, being a cheese eater, but that's a case where they're the only one that can defend these patients. So you have to make sure that you do tell a supervisor. I'll tell you a quick story because this is almost over. When I worked agency and I was floating back and forth from AC, I worked Shore, I worked Southern Ocean. One of those hospitals, I worked an orthopedic floor. And I would come in the morning, and when I would make my rounds, all of my hips and knees were in agonizing pain. And I'd be like, that's weird. What did the night nurse go to sleep? And I would go check them more, and they all got their pain meds. That's weird. Well, come to find out, and it wasn't just me, it was the other nurses too, because, you never know what you're going to get when you go in. We all have different patients, but we all were like, do you see that when you come in and what's her name leaves, everybody's in pain? Well, she was replacing their meds with saline, and she was taking them. Yeah, they took her out in handcuffs. It was sad. So at any rate, it happens. It happens. It happens. But now they're prosecuting nurses. They didn't used to prosecute people in the healthcare field. I mean, you could lose your license, right? Obviously, if you do harm to someone. But now they're prosecuting people. So just be aware, don't, if you feel like you're tempted because it's a high stress job, go in a different, teach. That's a fun job. It really is. I love teaching. But I never got stressed out from nursing, but some people do. They really do. So you got to manage your stress. You can't make it go away. Manage it. Last question, is the following statement true or false? It's best for a nurse to help a colleague in private who has a substance abuse disorder, then involve the facility in which they both provide care. That is false. If somebody, look at all those poor people that didn't get any pain med. And that's a whole sequela of things that happen. That not only is your pain increase, your blood pressure goes up, yada, yada, yada. So, you're ethically bound to do it. And that's all for substance use. I talked about the things you need to know, the disulfiram, the chlordiazepoxide, the time frame, alcohol and opioids are the two big ones. Okay. So the end. Ciao. Ciao, Bella. And see you later.